could I invite Tim and Mark to come and join us on the stage, and we'll have our opportunity for questions and discussion. So please ask your questions, and let's have a bit of a discussion. Grab a seat. There's a microphone here. Please, if you're asking a question, hand up, say if you could identify yourself and then speak into the microphone. The laryngeal recurrent laryngeal hemiplegia has also got a hereditary component, quite a strong one. What are we doing when we're implanting nerves into these horses? We're helping the individual, but is there a consideration for the breed and breeding on with these horses?
I'm happy that Tim answered. No?
Oh, right, yeah. I thought you were grabbing it there, Fabrice. We don't know. Or I certainly don't. I don't know if anybody does. I think as a profession, we don't know the heritability. There's a lot of talk, obviously, that for years it's been thought of that certain breeding lines produce all of these problems. But I don't think we know. And I think looking at recurrent laryngeal neuropathy, it's very dangerous to look too much at what is happening, because we have, if you've invested in an expensive stallion, you're then more likely to invest in a nerve graft, should we say. So we're skewing the population somewhat with our selection. And certainly, if you've got a less than £10,000 covering fee, you're perhaps not going to undertake the surgeries that we're talking about doing here. So we are definitely skewing the population with that. I just don't think we know enough. For me, I certainly don't know enough about the genetics of it. And I don't think the way that the thoroughbred industry is built, we ever will fully understand the genetics of these conditions in the thoroughbred. And equally, the warm blood populations that are similar, we won't get to the bottom of that either. A lot of it is husbandry as well. I mean, going back to the original sort of thought process as to what causes RLN, you very rarely see this in ponies, if at all. And it's a size-related, quick growth-related condition. We know that. It's basically that the nerve and the tissues surrounding the nerve and the various ways that the nerve axons are put together, they're growing too quickly and they outstrip themselves of the blood supply is one of the original concepts, and we don't know that yet. So, I mean, until we get to the bottom of that, if we ever will, then we probably won't know that. So to answer your question, I don't know. We don't know for certain, even if it is heritable.
Any other views on the panel?
Yeah. This is something I was thinking about and discussed briefly with Fred last night, that it occurred to me if it is heritable and if these issues have as great effect on performance as we all tend to believe they have, why haven't we bred it out of them? The one thing that Tim said that I took note of here was that if you've got a horse with left-sided hemiplegia, you'll bring it back in trip. They'll sprint. So is the current trend, the current need for speed and bringing everything back in trip, and the recent idea that a lot of stallions or a lot of horses are retiring at 2 and going to stud, is this perpetuating the problem and allowing the thing to continue?
I think I would say there's, for me, 3 aspects. The first aspect is it genetic? Probably yes, but it's a multifactorial. So when you prevent these things, you cancel also a lot of positive genetic component that you want to keep. And for example, like in OCD. OCD happened in a young show jumper that is galloping when he was a fall. Is a fracture of a young animal. So if you stop all the OCD, you will stop all the dynamic fall in the field. So you will select safe probably from OCD, but very bad sport horses. Genetic, yes, for sport horse. I don't know exactly. I have not a significant number of the same stallion in thoroughbred, but for example, probably 50% of my tieback in Germany happened for 3 horses, two or three stallions. The one stud farm was 2 stallions. In one stud farm, there's a minimum of one. There are 50,000 horses, but minimum of 1,000 a year they have. They don't operate all of them, but a huge amount, and just 2 stallions. So yes, they don't care, because this surgery in sport horse, especially the nerve graft, works well. So they prefer to sell a good horse with an hemiplegic than a bad horse. One of the 3 medalists, these are the Olympics. One was a horse had an hemiplegia and was one limit. So it's different in thoroughbred. I don't know everything. And about the technique, remember that for a nerve graft, the larynx will remain the same at rest, because the nerve is just stimulated at exercise. So whatever the surgery you do at rest, there's no failure. You don't hide anything. You see that the larynx is still paralyzed because it's moving a little bit, but it's still hemiplegic. There's no discussion. The only situation where the nerve graft allows a full recovery larynx, in my experience, there's 2 types. The very young yearling, where you have a transition paresis due to trauma or strangle or thing like this, and iatrogenic, often right side hemiplegia, where the nerve is just injured. So when the nerve is just injured, in some situation, young horses, traumatic, probably infection disease and injection, then the nerve graft acts just like a babysitter, we call that babysitter, doing the proper healing of the nerve to prevent atrophy. And then at the end, the larynx will be perfectly normal. But in all the other situations, which are the more common, the nerve is only activated at exercise. So if you scope a horse at rest, you will know that the horse is hemiplegic. So if you don't want a stallion with hemiplegic, you know it. But at exercise, if the nerve works well, the larynx will abduct.
Thank you. Celia, did you? Can I have a microphone for Celia, please?
Yeah, I guess I'm just reiterating points that all 3 speakers have sort of touched on, but there has been a group based in Dublin, Dr. Lisa Katz and Emmeline Hill, working on exactly this subject, trying to identify genetic markers for laryngeal hemiplegia. And I've been kind of witness to the whole thing from the perspective of an editor. And they have actually got it accepted. If it's not out yet, it should be any day now. But the biggest challenge, I think we all have this concept that there's a bad gene, and if only we could find that bad gene, we could solve that particular problem. But exactly as Fabrice has just said, it's multifactorial. Genes are not necessarily expressed. And this is another example, like OCD, where the good traits and bad traits are sort of all tied in together with the same genetic markers. So the reason that Dr. Katz's group found it very challenging to actually complete and publish their study is that there appears to be a very close relationship between the genetic markers associated with laryngeal hemiplegia and those associated with height. So it's not as straightforward. This one is good, that one is bad. We'll get rid of this one. We won't. We'll keep all the good, that's why it proves so difficult to study. Also, it seems like why haven't we figured this one out yet? But it's not just one gene that is somehow going to solve the problem.
Thank you. Do you not think that across all disciplines you shouldn't be allowed to sell semen unless you've disclosed any procedures that the stallion has undergone in training to enable him to achieve his performance? and let the breeders decide which ones they want to patronise. And then over a period of time, perhaps we'd have the statistics and the information we need to make informed decisions.
Thanks, Fabrice. Is that, in addition, airway problems and other problems?
Yeah, I don't see why a horse should not go to stud with a
Full medical history? I don't know if I can answer that. Mark?
You started your question with crossover disciplines and mentioned selling semen. Is this semen injected by the vet or by the stallion?
No, I don't see why it should be different for one sport other than racing. I know the
No, but-
interested in racing, but I'd like to know what's going
Can
on.
you just use the microphone, please?
So you presume you're saying the same for a thoroughbred horse, that we should declare any surgeries he's had before if he's going to stud. And I can understand that would be an ideal world. But in my brief time on the BHA, I think that was when some of the legislation on nasal strips, for example, and wind surgeries, not the declaration of wind surgeries, but before that, when we outlawed certain, mostly tack. And Tim Morris at the time said, when it was being suggested, how can you outlaw nasal strips and you can continue to allow somebody to chop half its larynx out? And he said, we must not legislate for anything we can't police. Well, I think what you're saying is sadly something we couldn't police.
I don't see why we couldn't insist that a stallion retiring to stud has a veterinary inspection prior to being able to be advertised, and that would include a scope, and they could say, oh yeah, this horse has had a tie back, this horse has had a tie forward, this horse has had. That's very easily achievable, surely.
Those on either side of me will be able to correct me on this, but I'm not sure it's that simple to say exactly what has and hasn't been done.
Yeah, I think the obvious removal of tissue and fixation of tissue is obvious on scope. There's a lot of other surgeries that can lend themselves to similar scars and will be hidden. I mean, I don't want to pick up the hot potato again of thermocautery, but where do we go with that? Tie forwards, you're not going to notice a tie forward without clipping and looking for a scar. And as I say, that region can lend itself to other surgeries, serratoiodectomies, as Fabrice alluded to there, for various procedures. So, policing it would be difficult. And it would rely on total honesty of the self-certification.
Pat Sells, Chasebourne Farm and Orbital Veterinary. We've talked a lot about surgery for wind problems. Slight elephant in the room. What about non-surgical solutions? Kate Allen's paper on her resistance mask. I don't know if she's here today. Is she? The Bristol group a few years back showed that she was pretty much fixing DDSP, improving time form ratings. I know a few trainers in this room have been experimenting with prototypes, possibly one up on the panel there. Do we have any vocal opinions from you guys that clearly don't want to put you out of a job if we find something that's better than surgery, but is this a line of inquiry we need to be looking at more?
So, for hemiplegia, except of the yearling, where you can have some incertitude about the real disease, I think the ultrasonography gives us some information if we wait a bit. Even if the larynx looks normal, we always make an ultrasonography not on the CL but on the CAD also. And most of the time we don't operate a horse if there's no early sign of atrophy. this hemiplegia in a progressive disease leading inevitably to a total paralyzed larynx. So there's no discussion that rehab in the disease that is well known will not have any impact on the success rate, and you need to go to surgery as fast as possible to increase the success rate. For the DDSP is a totally different. It's a fatigue of for the real type 1. It can be an immaturity or an inflammation, and definitely you need to treat the first disease medically. No. Many DDSP are, for example, in sport horse, are just asthma, coughing. Coughing lead to DDSP. DDSP never lead to coughing. Many vets, and so you treat medically. Immaturity is definitely the main problem in the young. I've never operated in my life a 2-year-old thoroughbred, never. We always wait for the 3-year-old, and most of the time, January, February, always, we wait very, very late, and we advise some training, some countering, alternate training, reinforcement, etc., to twist the fiber type 1, type 2. There's many work proving that the conservative treatment has the same success rate as many of the surgeries. This is the reason why, as a French, I think that the cauterization of the soft palate is just a way to wait, but it doesn't change anything. So we are totally convinced of that. So in the next hour book, this surgery will be discouraged strongly in the pharynx by Norm Duchamp. But it's my opinion. And we advise reinforcement and we advise medical treatment in all the horse until 3-year-old. And when they are 3-year-old, if I cannot clearly see on the treadmill a fatigue of the TH muscle in terms of vision is a descent of the larynx, ariperiodic fold collapse and swallowing attempt to stimulate the TH muscle, we don't touch the horse surgically, never. So to answer your question, yes, medical treatment is the key of the treatment of DDSP first, and we just replace the muscle, the TH muscle by prosthesis when you cannot. We have to do something because the resting season of the 3-year-old is arriving, and we need to do something. But if we find another solution, we do. I'm sure there's another solution. So Justin Perkins' work on the pacemaker stimulation. I didn't show you that, but we work a lot with the Medel company many years ago about the pacemaker for the larynx. It works well, but unfortunately it's forbidden for the resting regulation. And Justin Perkins made a great job. He had a DDSP, sampled the muscle, fiber type 1 low, fiber type 2 high, stimulate with a pacemaker the TH muscle, 50% of the day, 20 days. Check again, the horse didn't deplace anymore, and the sample show an increase of fiber type 1. So this is the only thing that the trainer needs to do. The question is he able to do that? Is he able to gallop, take time, countering? Not all of them. And the key of the success rate will be in the future. We are working with my resident of now magnetic stimulation. So there's magnet in human. They do a lot. They are very good in rehab. So my idea would be to put magnetic stimulation here in all the 2-year-old thoroughbred with a control group and try to figure out if they improve. But to answer your question, hemiplegic horse, laryngeal hemiplegia, yes, you need to rush to surgery as soon as you know there's a beginning of atrophy, because it will be never reversible. And DDSP, you need to try everything before surgery, I think, until you don't manage. But it's a totally different disease. Epiglottic entrapment, many epiglottic entrapment can be fixed by a medical treatment, but when the vicious circle happens, meaning inflammation, DDSP or DDSP inflammation or inflammation on epiglottic entrapment, you cannot move away, then you need to operate. But the surgery is in all the disciplines except the hemiplegia is always mixed with medical treatment, and sometimes the medical treatment wins. And as a surgeon, I spend more time for 10 emails for surgery. I think I keep 2 for surgery, and 8 I try to find another solution. And the more I do that, the more case I get. Because if you refuse 80% of the case you are supposed to operate, then the trainer will trust you more and more.
Mark?
And I think just to add to that as well, it's building on what Fabrice has said, it's diagnosis. And I think we have a good idea when we're looking at palatal dysfunction, which cases are thyroid dysfunction and which cases are muscle immaturity. So you're getting them in complex with nasopharyngeal collapse, and those will be cases that will lend themselves to the medical treatments, to the masks, because you can train that. I don't think there's any logical reason, unless Fabrice knows otherwise, how you can train the thyrohyoideus muscle in that way, but you can definitely train the soft palate directly, and you can train. So as Fabrice alluded to, and as I mentioned briefly, is those cases that are caudally retracting with clear thyrohyoideus dysfunction. It's unlikely in those cases that you would assume that the mask would work. In the more complex cases with the younger horses, but then you're also lending yourself that they may resolve themselves with maturity and normal training. But as Fabrice, there's a place for everything, and palatal dysfunction is such a complicated thing. I mean, there's all sorts of conditions that can cause DDSP ultimately.
Was there a question back there? No. Then based on what we've heard this morning, the complexities of what goes on in the throat, Mark, as a purchaser of yearlings, vendor of horses in training, and are the conditions of sale for thoroughbreds at public auction up to date and adequate based on what we now understand of what can go on in the throat?
Oh, I'd have to give that quite a lot of thought. It's quite. I think I took a note in one of the talks there, if I can find about back to the numbers of horses that are affected, and yeah. So I've said here, horses passing through the yearling sales seem that have passed the wind test. Anecdotally, it seemed to us at home that the incidence of wind issues in horses that had come from the yearling sales and passed the wind test, and those that were homebreds and had never had a wind test, was exactly the same. So I wonder, in my early days training, my attitude at the sales was, if it failed the wind test, I went and negotiated with the vendor and tried to buy it more cheaply. I then bought a few duds that went on to have serious wind issues, and I went to the opposite extreme. And to this day, our policy is that we don't scope beforehand. If we happen to be looking at X-rays in the repository and there's a scope there, we'll look at it. But generally, we just buy the horses, we send them for a wind test. If they fail, we reject them. And if they pass, we try not to think about it anymore. But even in that, I've got caught out terribly. One year at Fairy House, I bought a number of horses, and I got called to go to the vet box where Jeff Lane was doing the testing. And he said, of these horses, I've failed two. He said the colt, you could take, if you can get him cheaply, take him and do surgery. The filly, she's a disaster. Don't touch her at any price. I rejected them both. I don't know what happened to the colt. The filly won a group race in Italy as a 2-year-old and was Group 1 placed as a 3-year-old in France. And so I've gone back to wondering, should I go back to my old policy of buy them cheaply? I just don't know. So the one thing I would say about, I don't buy foals, but I occasionally sell foals, and I think it's bordering on unethical that so many people stick scopes up their nose when our experience with yearlings would suggest it's quite debatable, its value. So presumably as foals, it's of little value at all.
There is studies to show that foals can improve as well in their laryngeal function. We know that it's been presented that the foals can look horrific and then 2 months later they can look good again. So there is certainly a changing picture in the nerve supply to those muscles in foals. So it would be, I think it's misleading at most to be looking at foals.
Go ahead.
I'm Olivia Alton. I work for Weatherby's Hamilton, so I'm not a vet, so please be gentle. Something really stuck with me when you mentioned you'd operated on one horse 8 times. The ethics and the public perception were under so much scrutiny. I appreciate that's a trotter, not a racehorse. But are the rules getting stricter in this country to say, yes, you can do a minor wind-up and then a major one, but actually then enough is enough? You can't keep going back and doing them, because I think it could be hard to explain when people are looking more closely, saying, yes, this is a good racehorse, but it does need significant surgery every 6 months to maintain that. Is it right? Is it ethical?
You mean, is it ethical to operate a horse several times? Is to summarize your question, is that?
I think my question is more geared towards, do you think there needs to be any legislation on how much you can keep operating on these horses? Because I think I'm fully entrenched in the industry and I love the thoroughbreds, and I was quite shocked by that. So people that are on the outside looking in, I think they'd be quite horrified at some of it. I mean, these are pretty serious operations we're doing on these horses, and I think especially the nerve side of things is fascinating. But if you were doing that once or twice or multiple times in general, does it need to be regulated?
It depends also on the surgery. You know, a surgeon is obsessed by respecting the tissue and be safe and be gentle. And you can make an infiltration of a fetlock and be more painful than doing surgery. And as soon as in the throat you are not gentle and you have a disaster. So that's the first thing. The second thing is, in the sport horse, it happened to me to operate several times, to be honest. Sometimes they arrived, and I had a call 6 months ago. The guy, remember the horse you operated 7 times? Yeah, I saw it. It's perfect but it's sport horse. In thoroughbred, to be honest with you, we have one shot. It's very rare we repeat the surgery. And the thing is, it's not always. It's very rarely the second surgery. It can be very invasive, but usually very few. Teams show a little injection of PMMA or cement on the focal cord. Now we put just Nortrex. So we just do it very quickly, inject the bulking things. It's very safe. And what is the less ethic? Letting a horse coughing for 6 years and have a food in the nose, painful, being like this, it supply you to do something, or injecting 2 milliliters of Nortrex to have the horse safe the day after. That's different. And what is the less ethic? Doing immediately a tieback with all the risk, or saying, please, I think the nerve graft is much more safe because the horse will have a safe larynx and be like a normal horse, but I have only 60% or 70% of chance. And if it not works, it's up to you to do to the tieback. I think it's more ethics to propose 2 surgery, as soon as the first surgery is very delicate and very safe. So I would say the opposite. I think it's more ethic to add something but in the proper way, until the horse is happy and safe, instead of either letting a horse with a complication or starting with a very invasive surgery. So to answer your question, I think it's the opposite. But we need to explain that to the population. What we do that very commonly through the social media. And in my place, I'm obsessed by the new way of communication. So the social media of the clinic is based on that. We explain exactly what I tell you. This one I will explain you to the social media, exactly the way we do it. Because I think communication is the key in our work nowadays to explain things.
Diagnostics as well. He keeps saying this, but it is super important, and I alluded to that. And when we were talking about multiple diagnosis, the last thing I want to be doing is turning around to Mark in 6 months' time if he's let me operate on one of his horses and then say, oh yeah, and there was that as well, I forgot to tell you that, or I didn't tell you that, or we didn't do that diagnosis, and which is why we are so, Fabrice and myself and a lot of other vets that are in this room that I can see around here that do this surgery regularly, we diagnose them to within an inch of the life because we want to give the full story initially. And there's nothing worse than going back and finding something else. It happens occasionally, even with the most thorough of diagnostics, but I think it is important. And also, I'd reiterate to Fabrice's, occasionally it does have to happen, and occasionally you'll do airway surgery, then a couple of weeks later it'll chip a bone and you'll go back in and operate on that, and then something else will happen, then it'll colic and it'll have colic surgery. And you do have those horses every now and again, but watch the Freddie Flintoff documentary on the TV if you want to watch someone who went, I think it was in excess of 100 procedures. I know he had conscious decision over that, but high-end sports people are also undergoing huge amounts of surgical and medical interventions on a regular basis.
And just a little joke, there should be many people here in this room that have several surgery and are happy with them. So.
Yeah, my wife, who's here, thinks I just go to hospital for holidays.
One last question. Sorry, Rachel, do you have somebody over there?
Yeah, no, I think we've answered them.
Jamie, one final question, and I think it's time to go and settle grumbling stomachs. Oh, one more after. Jamie, go ahead.
My name's Jamie. I sell a few horses. Under conditions of sale here, we don't have to declare anything concerning the soft palate. In the modern day and age, is that good enough from a veterinary perspective?
We don't find that.
Don't have to. So under Tattersalls, is that in the Tattersalls
Correct.
rules? Yeah, we don't have to declare palatal issues. In yearlings, it's difficult for all the reasons that we've discussed before, and we often have this discussion. David's not here anymore. I do the wind panel with David and Johnston, and we often have the discussion of overground endoscopy and looking at them in more detail for all the reasons I explained earlier, but equally the counter-argument is the question that Kate posed as well with the yearlings. You will find a lot of palatal dysfunction in many horses presented for sales for a variety of reasons, including horses in training. I don't know, it depends. For me, I get the impression that some horses in training turn up in full fitness, some horses in training aren't in adequate fitness to assess their soft palate. I think it would be a very difficult thing to police, make decisions on because of that reason, because there will be such a variability in all those factors that would be normally. So, for example, if Mark asks us to go and do an overground scope, he's going to present that horse in as high a level of fitness as he possibly can for us to make an adequate decision. And I think even horses in training, some of those horses will not be in that degree of fitness. Would that be fair? Or am I wide of the mark there, Mark? And the yearlings is just a minefield. So to answer your question, I just don't know how we would do that.
One final question.
Thank you. Hi, Jo Haylock, equine underwriter at Liberty. Last year's lectures on OCD, they were looking at the size of the foal and the effect of that, if that predisposed them. And we were talking about the older mares throwing bigger foals. Is there any correlation, given you mentioned and it's potentially size related and quick growth related, between the time of year that the foals are born and getting these sorts of problems?
I don't know. I don't know.
I wouldn't know, no. I mean, I suppose the logic kind of I can see where the thinking goes. And once again, it just goes back to the thing, we just don't know enough about the exact
It'd be good to look
cause.
at like the data and see what time of year they are actually born and see if there's any links. Because it might play a part.
Yeah, the only thing I immediately springs to mind on that is back to the multifactorial situation that, would you stunt their growth to avoid them having a, because, clearly the negatives of preventing the fast growing of the recurrent laryngeal nerve is going to be the negative effect on the rest of the skeleton. So I think we're stuck with it.
I think we've got a new field of research opportunities there. And with that, I'm sure nutrition comes into it too. So we're going to go break for lunch now. And thank you very much. And a round of applause to our speakers.